Welcome, good morning, and good afternoon, wherever you might be. I'm Grace Rubenstein, Editorial and Communications Director with Health Begins. And here, along with our partner organizations, we are so pleased to welcome you to Coding and Co-Design, Social Care and Healthcare Lessons from the Gravity Project. A few housekeeping items to get you oriented before we start. Next slide, please. Just want to let you know that this webinar is being recorded. You will be receiving a copy of the recording and the slides afterwards, so don't worry about trying to write down every little thing. You'll also see often resources pop up in the chat, either from us or our presenters or from each other. We really like to make this a communal experience, so if you know of a resource that's relevant to the discussion that could be helpful to others, we really encourage you to drop that into the chat to share. As participants, your lines are going to be on mute, but we want to make this a real dialogue, and we're saving lots of time, even more time than usual today, for questions at the end. So the way to let us know the questions you have is to put them in the chat. And we're going to just do a little test right now to get that started. I'll begin by just showing my name, my organization, and where I'm coming from. I invite all of you to do the same. Make sure your chat box is set to send to everyone. There's Sam. Who else do we have with us today? There we go. Hello, Kelsey, Mike, Ingrid, Katie, Lori, Tara. So many of you from so many places. It's wonderful to see you. So this is a 1-hour presentation. We always ask that everyone bring respect, curiosity, and joy. We're going to cover a lot of great territory together today. Next slide. Our objectives, which you may be somewhat familiar with, are three. Describe the co-design process that Gravity Project engaged in to bring more social care voices into social determinants of health standards, creation and implementation. Understand a set of potential use cases for SDOH standards as prioritized by social care organizations, which can inform new standards and implementation guides. And finally, identify common challenges in health and social care integration that will be foundational to address alongside standard creation. We're fortunate to have insights into these as we went through the process, and we're really looking forward to sharing them today. Next slide. So with that, it's my privilege to turn it over to the fantastic Health Begins Senior Associate, Catherine Jantz. Catherine.
Hello, everyone. It's so lovely to see all of you, and I see many familiar names in the participant list. Thank you so much for joining. I am incredibly honored, next slide, please, to be introducing to you our esteemed panelists. So we have Sarah DeSilvi, who's the Director of Terminology for the Gravity Project. We have Janae Tyus, who's Senior Program Director of Mid-Michigan CHAP, a project of the Greater Flint Health Coalition, and Elena Kalinowski, who's Director of Interoperability and Collective Impact for San Diego 201 Community Information Exchange. So excited that you have the opportunity to hear from all of them today. Next slide, please. Health Begins is a mission-driven firm focused on helping Medicaid-serving systems move upstream and address health equity. We have a bold goal to advance health equity within 250 communities by 2025. Next slide, please. So with that, I'm going to turn it over to Sarah, who will provide you an introduction on the Gravity Project.
Greetings, everybody. It is my honor to be here with you today. I am coming to you from rural family medicine at the northern part of Vermont, so my apologies if there's any problems with my audio or connection. Next slide. I want to first just ground ourselves in a brief, very, very brief introduction about what the Gravity Project is, and then turn over the bulk of this conversation to the experts at hand, who are our social care voice experts and the participants in the project. The Gravity Project, just in general, for a grounding, is a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. If this is the mission and the goal, you can understand why centering the voices of social care expertise is critical for us to complete our mission. Next slide. We are very much a collective community of practice and action that are working toward that mission. These are our members and sponsors. We have an intentional design in our membership of making sure that we really center, again, those social care expertise and experts in everything that we do. We couldn't do what we do without our members, and we are very, very grateful for them. You can see many federal partners are part of the membership as well, but given the criticality of developing social determinants of health data standards toward the collective goal of health equity. Next slide. I am not going to go into this too much, but it's really important to know what we do at Gravity from the highest level. So as Catherine mentioned, I'm the director of terminology. That means I'm a language maker. I help with my team develop the words we use in standardized settings to tell the stories that are critical for patients and clients toward the goal of health equity. So the division that I lead, the terminology division, is the division of language making. And then there's another group, another division, the work stream called the technical work stream, which develops the technical architecture for exchanging that information and stories across different settings. There's a third work stream, which is called the implementation work stream, and I helped lead that as well. In 2023, I had the honor of assisting, partnering in implementation with our member Civitas Networks for Health, who helped support this work. In the implementation work stream, we then collaborated with HealthBegins on the Social Care Voice Co-Design project, and you'll hear more about that very shortly. But these three wings are the heart of what Gravity does: developing the language to tell critical stories, developing the technical architecture to exchange that information, and then, ever so importantly, implementing, testing, evaluating, and repeat. Next slide. Over the course of our now many years, we've been around for a little while, we've done a lot of work. So Gravity Project was born out of the desire to make sure that we could tell again those critical patient stories. Like there's an injustice of invisibility, a data justice principle, which is the inability to name the things we see. So that was really the primary driver for Gravity. How do we address food insecurity if we can't name the concern, define the things that we do to address it, and communicate with social care partners in common language? Over the course of our many years, we've addressed 19 different social risk domains, and we're still working on utility and security right now. We've had a couple versions of our implementation guide, again, that technical architecture. And as it stands right now, because of the evidence-based nature of our work, we are written into all kinds of policy, regulatory guidance. And we can talk more about that. That's on the Confluence if you want more information. Next slide. An example of the terminology storytelling capacity that we build is just detailed here very briefly. So screening encoded so we can share information on screening results. You can see the first question of the hunger vital sign there. Building the IC10-CM diagnoses to name concerns, right? So we built the language to define food insecurity. And then building patient-centered goals, and then building all of the interventions that we use to address them. Again, naming the critical people and programs that we connect people to address social needs, again, toward the goal of health equity. Embedded in this picture is also our 4 core initial use cases. Catherine's going to talk about them more going forward, but you can see naming codes, naming screening, naming diagnosis, naming goal setting, and naming interventions. And there's a lot more to do in the name of social care, so we'll talk about that shortly. Next slide. And then now I have the honor of passing it off to Catherine. Again, brief overview of Gravity Project, because the real mission and the real experts for this panel are our Social Care Voice Co-Design experts. I'm very, very grateful to see their faces again. And Catherine, thank you for having us.
And just a reminder that we will have a discussion with all of the panelists at the end. So please put your questions in the chat as we go throughout. And we'll be capturing those, and we'll try to address as many as we can. So next slide, please. So what is the co-design process? So Gravity Project and Civitas recognized a need to center the perspective of social care experts in order to improve Gravity Project terminology and technology deliverables. So with support from Robert Wood Johnson, they created a co-design process where 18 social care providers, the ones you can see on this slide, engaged in an intensive 12-week process with 6 two-hour meetings and homework between each sessions. HealthBegins had the honor of facilitating these sessions and assisting with report drafting. To allow for intensive collaboration, we really wanted the group to be less than 20 people. And so participants were selected from national and state-based organizations across food, housing, care coordination, WIC, and programs for older adults. These focus areas were selected because these are areas where there's been a high degree of health and social care collaboration. But this was not a one and done thing. This is a one step in a multi-step process of soliciting engagement, which you'll hear more about from Sarah. Next slide, please. So one of the things, well, the primary goal of the co-design process was really to improve Gravity project terminology and technology deliverables. The participants talked a lot about contextual factors, about how healthcare and social care are partnering, and the need for the overall context to change for healthcare and social care to have effective partnerships. And you may hear more about this later from Elena and Janae. But a couple of the key things we heard over and over throughout the co-design process were, one, there is a power imbalance between health and social care partners. And that power imbalance may need to be addressed in order for there to be the necessary trust for effective partnerships. Two, social care is not adequately funded, and that lack of inadequate funding impacts everything about how social care and healthcare can partner, including social care's ability to engage in data solutions. Three, we heard about several federal and state policies that impede the ability for healthcare and social care to partner effectively, especially as it pertains to data sharing and collaboration using technology. We also heard a deep desire to keep community and family members centered in the entire process, especially as it pertains to thinking about social care consent and control of our own data. But there was also a tension between thinking about consent and control and being mindful of administrative burden for both individuals in managing their own data and also organizations. And finally, the group talked a lot about the need and the opportunity for data to be supportive of clarifying and creating clear lines of accountability and responsibility across health and social sectors. Next slide, please. So one of the big outcomes of the co-design process was the identification of new use cases. So as you heard from Sarah earlier, the original conceptual model from the Gravity Project had sort of 4 key use cases: screening and social risk assessment, goal setting, and intervention. The social care providers in the co-design process identified a number of potential new use cases. These include holistic assessment, acuity assessment, care planning, collaboration and care coordination, eligibility and capacity, reimbursement and investment, individual outcomes, and population level outcomes. Within all of these use cases, both the new and the existing use cases, social care providers identified opportunities to refine the definition based on social care perspectives. For example, within the assessment use cases, there was a lot of discussion about the difference between an assessment needed to address immediate or urgent needs and the need to create a longer term, an assessment for a longer term plan or care plan. So with that, I'm going to turn it back to Sarah to talk a little bit about how the Gravity Project is using the results of the co-design process.
Thank you, Catherine and friends. Next slide. I just want to again state that, again, the point of, Catherine mentioned accountability within the process of the Social Care Voice Co-Design Report, and Gravity definitely considers itself to be accountable to the findings of the report itself. There are many ways that we're holding ourselves accountable to it. Again, we wouldn't have done this if it was a performative endeavor. And so on this slide, I'm going to try to detail what we already have planned, what we already are doing now, and what we have planned for the future. The first step is actually really critical. We've taken direct steps to ensure that we are better at embedding social care voice experts within our leadership. This includes directly reaching out to gather additional members to all of our governance committees, so that by design, those thoughts from the co-design report, everything that was mentioned, can be integrated into our work plans and strategy for future years to come. We also are already acting on the use cases that were identified. Each of the use cases from the co-design report has been put on our roadmap for evaluation of readiness. And that's partly why we're integrating social care voice experts, is to ensure that we have the right consensus body within our governance structure to upvote those critical use cases so that we can ensure they're addressed appropriately. We're already working on a couple of those use cases again right now, which is outcomes and payment and reporting. We're ranking just from an exploratory perspective. And again, the whole important thing to note is that Gravity's process is membership-led, and we're using and integrating our social care experts into that to ensure that we are accountable to the findings. We also have a pretty critical responsibility for awareness building. It's not just within Gravity, but externally, they were really trying to make sure everyone understands what came out of this report. You can see here, we're participating in Health Begins. Health Begins and Civitas have the same mission. This is the second webinar I've been on insofar as dissemination. But as a federally aligned project, this is also ensuring that these use cases are centered in planning across HHS. So when we're looking forward on what health equity planning and data standards planning might look like, and what infrastructure might look like, and how to align with the social care voice co-design with federal initiatives, we're braiding it into the elements from the White House playbook toward SDOH. We're trying to braid those concepts into the HHS data strategy. We're very accountable to ensuring the elements that were raised in the social care co-design process are integrated into everything we do. So overall, just want to make sure everyone knows before we pivot again to hearing from the experts themselves, the co-design really completed the mission for us, which is furthering Gravity's understanding so we can collectively execute on our goal to accelerate data standards to address the needs of community-based organizations and other stakeholders toward the goal of equitable health and social care. And I just want to note again, part of that reimbursement use case is adequately supporting social care entities in the work that they're doing. The votes on the co-design initiative know that means a lot to me personally. So very excited now to pass it back so that we can sit and listen and learn, as I had the honor to do last summer.
Next slide, please.
Yeah, next slide, sorry.
So excited to start hearing from Elena and Janae. So first, I just want to hear from both of you. Tell us a little bit about your organization and what motivated you to participate in the co-design process. And Janae, do you want to kick us off?
Sure, I'd be happy to start. So I'm Janae. I'm the Senior Program Director of the Mid-Michigan Community Health Access Program. We are the largest program of the Greater Flint Health Coalition, a nonprofit organization that's housed in Flint, located right in Genesee County. And what I have the privilege of leading is about a 10-year-old program now that really addresses the social needs of people who've been referred to us from a variety of different places. So this is what I do every day, in that I am sort of leading a team that's addressing social needs, having been identified, usually from a clinical or payer perspective. And the opportunity to really participate in this process is one that I couldn't say no to. It's an opportunity for me to sort of be a boot on the ground and a voice elevating that of my staff and our community partners, as well as those community-based organizations that we partner closely with. As Sarah shared earlier, this project has large implications for like future and legal things. So all of that motivated me to actually use my voice in a way that I know change will come from. So this was a super exciting opportunity for me. I think I was given it because of some of my statewide leadership as a state of Michigan HIT commissioner and leader of our community information exchange project. And it was just the perfect marriage in the opportunity to elevate those voices in all of the spaces and tables that I sit at. So thank you guys for the opportunity.
Elena?
Yeah, awesome. Thank you, Catherine and Sarah. Hi, everyone. Elena Kalinowski. Really grateful to be here. I am the Director of Interoperability and Collective Impact with the San Diego 211 Community Information Exchange, or CIE. And I'm also a social worker. I've been working in the nonprofit social service space for 18 years. And I've had the chance to work in a lot of different kinds of clinical settings, mostly that where that mental health, kind of clinical work overlaps with social care coordination. And then I also get to work within this wider systems level change, which I'm so grateful for. And if we can go to the next slide. Oh, it's not there. It's okay. Basically, I work for 211, which is the steward of our community information exchange. And basically, it can always be difficult talking about a CIE because there's no one manifestation of a CIE. I'm fortunate enough that, and I got to be one of the kind of founding designers and leaders for our locally led CIE and what that really means is we created this kind of infrastructural ecosystem that is both a legal network of health and social service agencies to be able to share data across each other's systems to create this really holistic understanding of not only what is it that people are actually accessing and who are they interacting with across the different systems of care, but also how do we actually use that to inform what we do next, and how do we actually come around someone and create that understanding of what have people tried, what have people experienced, what are people motivated and prioritized to access and use. And we use that with an interoperable platform that pulls in data and creates this kind of master longitudinal record that not only gets to look at what is actually happening right now, but also be able to understand progression of like access and services and impact and outcomes. Because one of the things we all know is that care coordination is an interdependent reality. My ability to go to a job is dependent on my childcare and my transportation and my health management. And there is no parsing away between those different realities of access. And so when we built our community information exchange, we were fortunate enough to have the opportunity to really center and build it around the existing care coordination that's already taking place in our San Diego community amongst different social service providers. And so as we've been able to build that out and both capture things like, yes, closed loop referrals, how do we show how we're interacting as providers with our clients within this system of care, and really taking some of that burden of care coordination and access off of people in need and putting it on our workloads as it should be. And so it also is really trying to create that infrastructure for knitting together these different systems that are historically siloed, both from a data structure as well as from a funding and care coordination lens. And so because of that, I've had the opportunity of both engaging with our social service providers over time and having them be a part of the community and really understanding workflows and understanding, okay, how does this kind of infrastructure inform what you get to do next around care coordination? And then because of that, I got to move into really leading all of our data integration and interoperability projects. So let's get down into the data and understand what is our language that we get to share on. And that gets to be the like emerging social standards that are coming out from Gravity Project, and also understanding how these different systems get to work together. And because of that, I also got to be involved with the Gravity Project for the last several years and get to work with Sarah and amazing people who are really trying to solve for a massive system change, endeavor. And because I get to sit both on the steering committee and the operational committee, but I used to also co-chair the technical advisory committee, and it really lent to the awareness of how much we need to understand implementation and consequences of what does this look like in a social care setting if we're trying to really create a technical IG for this interoperable system. And so that's why kind of one thing led to another, and I got to be a part of the social care design and add some of the things that I've had to learn in a real trial and error hard way. So yeah, it's been a really cool experience. And I think it's also, as we evolve at our own locally led CIE, we get to work with other communities that are also trying to figure out how are we knitting together both not only just our actual technologies, but our workflows and our understanding of the people we serve in a holistic way.
Thank you so much. It's always inspirational hearing your motivations and big picture lens. So the next question I want to ask both of you is, if you could wave a wand and make one change to the health system or the data structure supporting it to improve healthcare and social care partnerships, what change would you make? Janae, do you want to kick us off?
Yeah, I think I'll start. I've been thinking a lot about this, especially because I've got a couple minutes to sort of expand my thoughts. One thing that I really think I'd love to see if I could wave a magic wand is the fact that the healthcare system recognizes providers and community-based organizations like myself as providers. We really do, as social care coordinators, see needs and prescribe things to meet those needs. And I wonder sometimes if the healthcare sector or system really recognizes how important it is for a person that is identified as having a food need or a financial barrier that's preventing them from using or utilizing their healthcare benefits appropriately, that they need some major support. And what makes an individual healthy doesn't occur in the clinical setting. So it's really the 80%, the social determinants of health, those physical, behavioral, or environmental factors that the wonderful team that I have the privilege of leading really do make strong strides and great attempts to close the loop and make sure that person has what they need. I think that's extremely important for the health system to recognize, just as much as you guys are tracking and capturing information about diagnoses and who that person is. We as social care providers need to do the same in order to do our due diligence and really achieve health equity. So if I could wave a wand, I just hope that one day all the healthcare providers really realize the importance and maybe lifted it up a bit more about those social care providers who are going to go ahead and meet those needs. So that's, I think, we are on the way, right? This conversation that we're having today is sort of, I'd say, balancing the scales of that being recognized. And I think there are just a few more major strides we can take in order for us to be able to share and sort of capture data in a manner that serves us all in a better way, that really just centers the individual and the entirety of their care. Looking at the whole person requires that the healthcare system really see CBOs as providers just as much as they are.
Oh, Janae, thank you so much. I think so many of your comments really resonated with me, and I'm sure much of our audience. I really like your comment around needing adequate data tracking to ensure we're having the health equity impact we want and closing the loop, and really overall the importance of social care providers. Elena, what would you do with your magic wand?
Well, since we're starting from a premise where we don't just have a fully funded healthcare system and social safety net, where we're not spending resources on means testing and eligibility administration, with that given not being on the table, I think when I think of my magic wand, I think we have a infrastructured system that fundamentally gets to allow people to access smoothly across sectors, that does not force people to partialize who they are, but also allows people to say, in different settings and in different contexts, different parts of who I am are relevant and matter. And they should matter when they are relevant and helpful to me, and they should not matter when they're not. And, and I always use myself as an example. I'm a queer person, and that comes up when it comes to accessing different things. If I need a food box, that's a little less relevant. But if I'm accessing, mental health services, or I'm looking for, different kinds of groups or things like that, I want to be able to find services that are tailored and specific to the realities I experience in this life. And I think, like, when we talk about an ideal state, we have an interoperable system that doesn't unfortunately prune away important textured intersectional data that a lot of times is housed within a social care setting, because we are trying to move towards standards that gets to be that lingua franca that we all speak. And so how do we both sustain that that ability to capture that complex reality of a person's experience and situation without also making it where we have inherently siloed systems? And so I think that the kind of like portion of who someone is being able to be relevant in a helpful way and allows them to access services in a streamlined way that is not based on demonstrating just how desperate their situation is, or how eligible they really are, or how severe the situation is, but that things get accessed in tandem, because that's turns out how people need to access services. Is that if you have a move-in date for a new housing, but you've got someone to help pay arrears, and you need moving costs, and you don't have any furniture, or all the different realities, they go hand in hand. And we can't think about services in these like itemized ways. In real life, they have to be accessed in tandem and in coordination. And that's why our system needs to be in coordination, because that's how humans live. And I also think, like, our system will, in an ideal state, not just center people in this kind of vacuum. And I think sometimes when we talk about people and data, it's this very centered on this very patient-oriented record, when in real life, we live in context, we live in relation, and we live in community. And who we are and our families and the roles we play shape our priorities, shape our goals, shape our what are we even trying to access in the first place. And our system gets to reflect that and be responsive to what someone prioritizes and wants and looks for.
Thank you so much. I love that you touched on some of these contextual factors that kept coming up for the co-design group, and especially want to re-emphasize your comment around this need to demonstrate how desperate they are. I think there's these interesting cultural norms we have that may be getting in our way of effectively providing services. And I think that's something that came up in the co-design process so often. I'm so glad you emphasized that. So I have one last question, and then we're going to turn it over to audience questions. And for those of you who are sitting on a question, there's no bad question. The participants in the co-design process can tell you there was a steep learning curve for some of us in learning about gravity. You can direct questions to the group or to Alana, Janae, or Sarah. So my last question for Alana and Janae is, what do you want all our attendees here today to know about the learnings that came out of the co-design process? Janae, do you want to kick us off again?
Yeah, absolutely. So, I think that one of the first things that I felt was welcome in an environment that I am not alone, that health-related social needs, as we know, are everywhere, and everyone across the country is trying to figure this thing out, and no one really has yet figured it out. So what I was able to sort of experience through the co-design process was really just affirmation that we know what's happening, we know what we need to do, and we are all trying to work towards process progress, right? And really understanding each other and the complexities and coming up with something that works for the majority or works for all. And in that space, all of the voices were elevated. I think that it was just important for me to share today that it's probably many of you on this webinar care about social needs, or you are a community-based organization. Maybe you are a care coordinator or participating in this space, and maybe you're interested in learning more. But it's really important to tap into projects like this, where you can read and learn and grow and participate and really advocate for change that would work for you. That was one fantastic thing that I loved about this experience. And I want all of people to walk away today with a hunger and an encouragement and maybe a kick in the butt to go read and do something and share and participate. They've got so many places and spaces for us to just tap in and provide our perspective. And although the co-design process is unfortunately over in that current state, I know there are spaces where they're elevating voices like mine and like yours in the future. And there is an opportunity. Sometimes the closed mouths don't get fed. So I encourage everyone to just find your voice, find your language, and find a space to share it, because folks like Gravity, Health Begins, they're just waiting and ready for people who know what's happening on the ground to share. So that was one wonderful thing that I really did appreciate about this experience. And I hope that others, there's like 300 people on this call, kind of do the same.
I don't want to miss this moment, so I feel like I'm gonna go off script and ask Sarah, could you just give a one-liner or put in the chat? How can people engage? Now that Janae has put the challenge out there, what should attendees here do?
It's funny, I was just trying to find the Join the Gravity Project link. So the great thing about, the great thing about Gravity is it's an open public consensus initiative. We welcome all of you. And we specifically we welcome all of you to our 3 workstream meetings. They're all public, and I'll put information on that. I'm going to drop the link in how to find the meetings in the chat. We want all of your voices to be part of the work. We need you. If that is not clear after this webinar, I have not done my job. And then also, if you feel like you represent a voice that needs to be part of our governance, let us know. Like if you have a perspective that you feel like is really critical for strategy or planning, or if you want to make sure that your voice is part of the table, we want to know that too. All of that is part of our structure. We're open and public and consensus-based by design. I'm going to drop a link on how to make it easy once I can navigate it over there, because Catherine dropped that. I hope that's clear. And we also want to state, Catherine made this clear as well, this was the first phase of the code design, focusing on that's first mission. We also imagine that other versions and other gatherings with centering other voices are going to be important in time, centering education voices, legal voices, and voices within Indian Health Service and tribal entities. Our work is not done. Our mission is broad enough, and it's a social mission. So we're also hoping coming soon to a co-design process near you on that topic as well.
Thanks, Sarah. Elena?
Awesome. Yeah, I just want to like echo what Janae said. Everything, like, I think that's so important because social services represent groups that, you know, everybody has a body, so we all access healthcare. But social services are often representing people who don't have structural voices. And so how do we really make sure we are centering those voices and bringing them forward? And so I just thank you, Janae, for noting that. I would just say one of the core takeaways too is addressing SDOH needs is not I made a referral, they got some food, they enrolled in, you know, a benefit, handled. That's not what it looks like. That's not what addressing and creating a holistic structural needs understanding and connection to supportive services is. And so I think like, you know, if anything, I think came from this, so the social care co-design as that really also stood out to me is like the true complexity of how people get available services, which are already, as noted, deeply underfunded. And so most often, in order to get a service, you have to not only have the need that the service provides, but also, are you part of the group that this specific service is specifically funded to serve? You know, I might have a housing, you know, a voucher for you, but I only serve people who are former foster youth, queer kids living in this one zip code that are ages 16 to 24. Like, that's the reality of access. And so the navigation and connection is not this, we found a need, we found a service, solution handled, look at us addressing SDOH needs. That's not a thing that's ever going to happen. And for us to really, I think, actualize the work of what the Gravity Project is helping us, giving us tools to be equipped to do, is to really understand that, like, we need to think about things in that holistic way, the same way Janae already just said this, of like really understanding the fact that people's lives are complex, and our systems are also complex. And if we build systems to streamline interoperability, we need to center that reality and not try to go to the most quick, simple, cheapest solution, because that's not going to actually solve our realities and problems that we need to come together and actually solve for. And so I think really understanding that holistic understanding is captured throughout the systems of care. Healthcare is a domain within people's lives, a really important, powerful one. But it is placed within the context of all the other parts of people's lives, and how different service providers are understanding someone's situation and the depth of that situation, and trying to do that complex work of care coordination requires a lot of different types of information that comes from different sources. And that's, I think, the power of standards, and that's the power of the Gravity Project, being able to give that shared language to be able to say, hey, in order to really take this information to do care coordination and make it a meaningful activity, we need to be able to pull in this data and understand what to do in a way that benefits people and gets them quicker and smooth access, rather than, you know, having them jump through hoops. So I think that really centering the reality of what we're aiming for in this project is not ever going to be boiled down to a nice, simple solution of a screening tool and a closed loop referral.
Elena, thank you so much for that. So I think Janae gave you a challenge to engage, and Elena told you why we need you, because the system is so complex and we have to do the work now so that we build it in a way that will work holistically for people and the systems that serve them. So with that, I'm going to turn it over to audience questions. So, and we'll invite Elena and Janae and Sarah to respond to any of these. Our first question is from Janet Perkins, and I apologize if I mispronounce anyone's name, but it's how or where does a CBO or community health and social service collaborative begin the process of translating and adapting Gravity's proven practices to their local environment? Is there someone who can take on, like, what does this mean on the ground? How do you start adopting Gravity standards?
Do you want me to start with that one? Or I think about Elena. I think
Go for it.
I'm going to start with I think I would start with you start with what you need to do, right? So I want to be very careful that the complexity of the standards that we build within Gravity are not appropriate for every single setting and every single purpose. And we do not have the intention to add complexity to the base daily work of what CBOs are doing on a daily basis. That would not be the mission, right? And so I think the most important thing to do is initially do a landscape and see what information is helpful in the collaborations and partnerships you have or built into any regulations. The same clinical practice. It's always start with what I need to do. And then Gravity. And then if it's not clear, I put in some links. If it's not clear from our implementation materials or from whatever guidance you're getting for data standards, what you need to do, then come to Gravity and we'll help, really. We just want to make sure that we're not shifting the burden on documentation from clinical entities to social care entities as we try to create standard language. And I just say that from a point of like responsibility perspective. Elena and Janae, I think, because I want to take over the CBO voice, but that's the Sarah DeSilvi data standards policy maker voice. Does that seem like a fair? Then I pass it off to my brilliant friends. Elena, Janae, any follow-up to that?
Yeah, I think like, you know, because I'm coming from my local lens, so just know that, as part of our community of our CIE, I think there are infrastructural movements happening in communities throughout the country around how are we able to participate in different kinds of kind of using the standards and using data sharing, and that can look different for a lot of different ways. And I think, like, you know, in practical real life, as a CBO who works with other CBOs, and like how are we using both standards but also like creating interoperable systems, it's a huge part of trying to it's driven by CBOs trying to make successful care coordination infrastructure. They're already doing that. A lot of times, like when it comes to using their CIE and being a part of our CIE and like having systems talk, it's because CBOs are already care coordinating and they want to be able to demonstrate the impact of their outcomes and say, yeah, because I provided this housing program and you provided this childcare program, look at the stability we helped, you know, infuse into this person's situation. And I think like there's a lot of different ways that gets to look. And a lot of times we don't need to share a crazy amount of data to be able to understand how we're all a part of someone's kind of system of care. And I think that deeper understanding of how this system works together is kind of self-evident for a lot of CBOs, and there's different movements around. Most CBOs even know like HMIS, it's kind of an existing interoperable system in a lot of ways of like, hey, we're all trying to connect people in prioritized ways to housing services that are limited. How do we do that? Well, we got to come together in some way. And so it's not like this is brand new, I guess is what I'm saying.
Thank you. Next participant question that I want to respond to is from Nicole Richmond. What are some suggestions you have to address trust in the system to share one's data? And I'm going to see if Janae is up for starting us off on this one.
Sure. Trust is a big deal and it is the key. And I think you need it first. So one of the things that I leverage here is that we employ people who are trustworthy. They've got lived experience, they do the work, and they have a natural ability to build rapport, and they They really don't poke around about things and make people feel uncomfortable. We use language that's clear and it's easy for people to understand. We're mindful of what people need to know, and we're comprehensive in our approach. So we have sort of a consent form in CHAP that I'm sure all my staff love, but what it does is truly outline who we are and what we do, what sort of data we are asking or capturing, and then what that data in our environment or ecosystem may end up doing or being in an aggregate or sort of on an individual basis. And I think starting the relationship with clarity up front is key number one. Employing folks is key number two that are already trustworthy. And I think if you're in the state of building, encourage people who are trusted members who might even experience or participate in your system to help you build your data system. People trust what they know, right? And they trust what they've been given an opportunity to tap into. So those are a couple suggestions. I think I gave about 3 that can help sort of overcome the issue as it relates to sharing data. And I think you also need to be clear about allowing folks the opportunity to opt out of that data sharing. If they decide that, hey, that's not my jam anymore, I want to revoke my rights, make sure they're clear up front too how to do the same.
Thank you. Your answer was so helpful that I think you're getting a request to share your policy and procedure around training staff on the consent and trust building process. So thank you. That was really helpful. I'm going to just move us on to the next question because we have a ton of great questions. How does the work Gravity is doing? So Sarah, I think this one might be a good one for you to start. How does the work Gravity is doing align or not with the ICD-10Z codes related to SDOH categories?
We made them. Yay! So that would be crystal clear alignment. That's one of the things that was actually one of the originating drivers, is a need for that basic communication. Like what is the kind of information that travels the swiftest and is linked to the most policies and regulations? It is the IC10-CMZ code, right? So one of Gravity's first reasons was trying to improve the granularity of Z codes because of how they're linked to everything: risk stratification, quality measures, in lieu of services, payment and reporting, surveillance from the CDC perspective. Those codes are so critical. And we can already see them being built into federal policies now that they're existent. We see how the Gravity homelessness codes are part in risk stratification. We see how the IC10Z codes are part of in lieu of services documentation. So across the 19 domains we've referenced, enhancing IC10-CMZ codes is one of the most critical things that we do. We just submitted a digital literacy IC10-CMZ code at the March IC10 Coordination and Maintenance Committee meeting. I did put in the chat our reference for how one could get to IC10Z codes from the very common Accountable Health Communities Health-Related Social Needs Screening tool. One thing I want to note that's important, because the question was just based on trust, there's a big gray line between the questions and the diagnoses. That big gray line is where people come in. Gravity is very careful to say, from a trust-based perspective and a person-based perspective, we confirm things in conversation, centering people with consent. And so there is no direct map from a question to an IC10-CMZ code and anything we do based on our principles and our values. So I can't suggest IC10-Z codes without stating that. And the resources in the link up above, I tried to furiously gather things and put them in the chat. And you can find all of this information in the resources for implementers section within the Gravity Confluence.
Thank you, Sarah. So we've received a couple questions about, this is all great. The standards are great. The conversation is great. But we've received two different, for sort of similar questions. But how is this being connected to what payers are doing or requiring, or policy requirements that are sort of motivating healthcare providers to do screening or referral and Z coding? And so just want to hear a little bit about, how is this playing out in reality with the activities of payers and providers?
Me? No. I don't know. Can you repeat the question? I thought it was not going to be me. So can you just do the
so the question is,
I'm here to
how there's two different questions. I'll read both of them. So
Okay.
healthcare and CBOs being connected rationally is critical, but What about how this wonderful work is being connected to what payers are doing or requiring? So that was the first question. The other very similar question is, based on my experience, healthcare providers will only engage in SDOH screening and referral if it has an economic benefit to their healthcare system. I think this economic benefit will need to be demonstrated in either a fee-for-service realm, such as reimbursing for ICD-10Z codes, or in a value-based realm, such as reducing total cost of care. Does the Gravity Project see its work as addressing this situation? If so, how?
Okay, sorry, you can see why I lost it. It needed to be repeated. That's a dense one. Luckily, I can try to lean into it because I wear a few hats in the ecosystem. And so this is kind of a made for Sarah question. So what I'm going to start with is that within the Gravity model, payers, including CMS, are a critical part of what everything that Gravity does. So aligning with payer expectations and payer standards to support, again, that shift of monetary resources and reimbursement to social care entities for longitudinal sustainability, that's in our strategic roadmap, right? Ensuring that payers and CBOs and social care voices are partnering in the solutions to sustainably support social care entities is part of what we do at Gravity. And you'll see in our membership, payers are everywhere, right? And so I'm going to state, so it's kind of, we try to do this by design, not to say that that is not a, that is the solution for complexity. Elena is very critically involved in our payment and reporting use case right now. The complexity of the ecosystem, depending on the payer and project, is vast. Like it's just immense. Right. And so part of what we're trying to do in that work is focus on like one use case, such as 1115 waivers and Medicaid, and figuring out how to standardize that, right? And then extrapolate to other use cases. The last thing I'm going to state is regarding the we do what we get paid for. That's in part true. We also get in family medicine. We do what we get told to do. Right? So this is where regulation and quality measures actually come in. So the Gravity standards are the heart of pretty much every federal regulatory statement and policy driver. So by aligning with these standards, you're aligning with what you're required to do, whether it be NCQA, or whether it be CMS, or whether it be CMS special needs plans, or whether it be EHR certification requirements, right? So you can do things because you get paid for it, and you can do them because in the name of health equity, the system recognizes it's important, and that is part of the mission as well. But I do want to note from a reimbursement perspective, there are lots of new reimbursement strategies. Gravity just had an implementation affinity meeting regarding the new calendar year 2024 HCBIC codes and how they're really designed to shift money to social care experts in social situations in the name of coordination and collaboration. Again, collaboration and payment and supporting sustainability, all co-design findings and use cases. So I'm going to try to drop the link to that recording and the webinar as well. You can also find it because those, again, the system is also trying to incentivize ways to support monetarily the things that they know are critical from a social care sustainability and from a health equity lens. Whew, I hope I did a good job there. That was a dense one.
Thank you so much. Okay, I'm going to ask one that I'm hoping will be a good one for Alina and Janae. So the next question, we got a number of questions in this vein again, so I'm going to take liberties and reword it. Is really how can we use the data that's collected and the information that we glean from this sort of standardized data process to drive systems change, whether that be at the community level or in terms of figuring out how to make a case or how to invest better in social care. But sort of what's the opportunity for using this data in an aggregate way?
I think I'm going to start, and I'm sure Elena can add. This is what I love. Well, I love many things about my job, but one of the things that I love and I encourage my team to do is just to document what's true for you and what's true for the person that you're serving. So in our world, we serve probably about 2,500 unique individuals a month with various social determinants of health needs. And we're constantly looking at that data, seeing who is in need, for what they're in need of, and what are the resources out there to meet those needs, and if there are gaps in some of those resource fundings. So being able to collect the data of the demographics, the complexities of that person and their needs, and the number of individuals kind of repeating with that need and needing to be connected to community-based organizations that can honestly be strapped for cash and resources and everything else, allows us to see where we need to advocate for change, whether it's policy or more community-based funding, and where we need to put that at those resources. So data is like issue number one. If we can capture the correct and accurate data, we can be informed about what we need to do. And then hopefully one day get in a space where we're not reacting to folks' needs, but we can predict them, right? And we can adjust that from an upstream approach versus having to do so downstream. So data is a big deal for me. And I think that if we're smart, this whole process is all about capturing data in a way that is standardized, it's across the board, and it's helpful for us and others in the future. That's how we get to the health equity for me.
Absolutely, to what Janae just said, because I'll just add, so, and I know I'm like a stereotype of a social worker here, but like, I always think of things inherently in a micro, meso, macro lens. And I think, part of what's powerful about standardized data is, to Janae's point, is that you get to understand what are we looking at on all levels. And I think when we start talking about that meso and macro lens of not only, hey, how's my, within my organization, my population health or population outcomes or things like that, and needs. But I think one of the biggest pieces is the standardized data gets to be how we also get to layer on and reveal the many structural inequities baked into our systems. And that when we want to start changing, like on system level, what does it mean to have barriers to access? And not in some abstract way, but in like, no, as it turns out, if you live in this zip code and are not white, or you are disabled, or you're an older adult, these are some of your consequences. Like I think when we talk about how we actually structure our systems, that's what data gets us to do, is it allows us to say, this part of our system needs to be improved and reworked. And I think that's one of the things, and again, I'm always coming from that CIE perspective, so I apologize. But, when you have not only the standardized data, but also the data that shows like change over time and outcomes, and what are the variables in play. I think that's when you get to really start revealing how to create a more equitable system, because it's not. And how do we do that?
That was a great response, both of you. Thank you so much. I'm really tempted to ask one more question, but want to be respectful of everyone's time. So might close it there. I just want to call out that a lot of the questions we got that we didn't get to, I think are exactly why we need more voices as part of the Gravity Project and other efforts defining how healthcare and social care partner. We got questions about how are we making sure that coding is trauma informed? How do we make sure people that people are comfortable with how they're being labeled? And so I think a lot of those questions that you're asking are exactly why your perspective is needed at the table. So I encourage you to connect in many of the ways that Sarah listed here. And thank you so much for coming today. So a couple end of meeting housekeeping items. First of all, thank you so much for joining. Thank you for your fantastic questions. We will send out a recording. When you hit close, you'll get a pop-out survey. It's really helpful for us to get responses to this survey. So thank you for responding. And stay in touch with us through Twitter and LinkedIn. Feel free to tag us if you have reflections based on today's meeting. And I would encourage you to read the report. It's a really fantastic report. And I hope it's useful to all of you. Thank you. And we hope to see you on our next webinar.
Thank you.